Okay. All right. I think there is some echo. Okay, it's okay now? Yeah. So, intraocular lens implantation in infants, you know, is it based on age? Probably if you look at 7 months to 12 months, most of the people are comfortable. And the next age group beyond 12, I think there is already consensus. So, in infants smaller than that age group, is it possible? Why? There is a big change in the first year of life, right? There is a big change in the axial length and the keratometry value. What you can see here, it's significant change in the first few months. And also, unilateral and bilateral cataracts are totally different. Unilateral cataract leads to unilateral visual impairment. The etiology is mostly local. Bilateral could be bilateral pathology. They could have systemic, and they have more visual impairment because that will affect their visual development. If you look at the 10 years infant phakia treatment study, what is happening? The intraocular lens group, the first year, 34 resurgeries in the intraocular lens group. And in the contact lens group, when you add in the 6 to 10 years, there is one more surgery happening there. So in the long term, and this infantile phakia treatment study is mainly unilateral cases. You need to remember that whenever there is unilateral, there could be PHPVs, there could be other reasons. So it's a different ball game what you are speaking. And you see number of patients with at least one procedure in the first year in the intraocular lens group also is 36. So what is the exact difference between the infantile phakia treatment study is this slide. In the intraocular lens group, complications are more, parenting stress is more, expense is more in the first year. But in terms of visual acuity, strabismus and glaucoma, there is no change. Can we extrapolate this? Because when you have a methodology of a randomized controlled trial, allocation of the patient is important. Corneal diameter is important because unilateral usually will have a smaller corneal diameter. Age is not the only criteria we should be taking. It's the eye we should take. Intraoperative finding, steroids, how much you have given, whether it is 4 times, 6 times, 8 times, 12 times, pre, intra and post-operative factors, socio-economic factors, because we are working in a diverse world where the socio-economic status can be different. US, Europe, probably Middle East or India or Asia, it could be different. And availability of insurance could be different. So these factors, we have to see whether the ideal versus real world. When you do a randomized control trial, it's an ideal situation. People will come for follow-up. Everything will be taken care. But it's different. So we need to consider age. We need to consider corneal diameter. We need to consider other anterior segment dysgenesis, not just cataract, laterality, intraoperative findings. Because if I have done only 1 or 10 pediatric cataract in my fellowship, I might have more complications. Intraoperatively, I might see a bleeding there. So then I don't want to implant a lens there. Socioeconomic status always I need to consider. I'll come back to it. Why? Surgical experience. If I am doing a infant cataract with the implantation in my first 5 cases, I am going to really make more complication versus after few surgeries. And also magnitude of childhood blindness, if you see, affluent countries to poor countries, the ratio is much more. So, when you talk about these countries, we need to have a different strategy compared to others. And congenital cataract, the highest prevalence is in Asia, not in Europe or US. So, the cost of IOL in USA is 7,300. For example, in India, it will come to around even less than that. FAK is somewhere here. And this is a 3 to 5 years follow-up. If you see, they have a longer. And after adjusting for their respective GDP, US GDP is 7.5 greater than of India. I have given an example of Indian scenario here. So majority of cataracts are in Asia and Middle East and Africa. And follow-up pattern is a major concern. This is one of our studies published in BJO. In the first year, there is a drop. Whatever you do, there is a drop in the first year, both in the paying group as well as, affluent versus non-affluent people. So, bilateral versus unilateral, socioeconomic status, age and the eye, and the experience and intraoperative findings matters. This is why toss of a coin, which happens in a randomized controlled trial. So, whether they will go into contact lenses or IOLs. Can I? Okay. So, what is important is when you looked at the long-term follow-up of primary IOL implantation in younger than 6 months, it's pretty safe. It's not that I am able to implant in every patient. Don't think that age is a criteria where I can implant in every. Half of the patient we can still implant, and more than 6 months we can implant in 75% of the patient. And this is the most important slide for a decision factor in terms of implantation versus no implantation. I have to look at the biometry, ocular comorbidity, surgical experience, intraoperative finding, socioeconomic status. And if some of these are coming in the way, I will defer IOL, because I am not here to debate only for IOL. I am here to say safe IOL things. You can do it in this kind of situation. And this is the publication what you have made. Everything is there in that particular publication. If you can just show that slide, we can learn more about it. This is the whole thing. It's a 5-page article we have written on the safety aspect. So once again, I will conclude my talk saying that with the safe technique, good selection of patient, IOL implantation is possible. But at the same time, I will say every patient, it is not possible. Don't take age as a criteria. Look into the eye parameters and then take the decision for IOL implantation. Thank you very much.